Buddy. This is CACNETS. We meet every month, the second Saturday of every month. And today we are welcoming a very special speaker to our group. I'd like to introduce her now. Tara Whyand is London-based and internationally recognized NET's oncology and gastroenterology dietitian-nutritionist. Ms. Whyand is in private practice, offering her services via video consultation to neuroendocrine patients worldwide. I hope she will tell us how to contact her for that service, what she charges, and how such a session might ensue. She also has an excellent series of brief NET nutrition YouTube clips available to everyone. Previously, Tara worked at the Royal Free Hospital in London for 8 years. She is on the advisory boards for ENET's Nurse and Dietitian Group, that's part of the European NET Society, and Neuroendocrine Cancer UK, which is an organization very similar to our Carcinoid Cancer Foundation. She recently presented at MENET's World NET Lives Conference in Israel. That's the Middle East NET Society, in conjunction with INCA, which is the International Neuroendocrine Cancer Alliance. She ran the dietary side of their diet, exercise, and psychology program. Ms. Whyand is a member of the British Dietetic Association, as well as, do you say this, UKNETS?
Yep.
UKNETS, which is the UK Neuroendocrine Tumor Society, and ENET Society, and has a BS in human biology and an MS in human nutrition and dietetics. Ms. Whyand has researched and written multiple articles on dietary factors related to neuroendocrine tumors. I have one, where is it? Printed it off. Anyway, I have one that I printed off from the web. She wrote this in conjunction with the Royal Free Hospital in London. It's called Gut Surgery, How Diet Can Help. And she wrote it in conjunction with for the NET, let me get this straight, the NET Patient Foundation, which is now called the Neuroendocrine Cancer UK. Tara has also written articles on somatostatin analog use, IBD, and other gastrointestinal disorders, as well as respiratory disease and breast, prostate, and pancreatic cancers. Ms. Whyand speaks at national and international conferences, pharmaceutical companies, and Neuroendocrine Cancer UK, and now to us, thanks to Zoom for making such long distance speaking engagements available. So with no further ado, welcome to CACNETS, Tara. We are eager to listen and learn.
Thank you. I'm just going to share my screen. I've never done this either. Okay. Okay, hopefully everyone can hear me and see me. Can you give me a thumbs up, someone?
Tara, you are the only face on the screen right now.
Hopefully that's a good thing. Okay, right, let me...
Everyone else is on blocked video.
Lovely, okay. All right, so let's make a start then. I might just hide myself so you can see. Yeah, that's right, okay. All right, so thank you so much for inviting me. I've put together a presentation which briefly covers digestive issues. Obviously, it's not everything that we do as dietitians. There's lots of other things that we come across. However, today is just to kind of half an hour intro to the treatment that we do in terms of dietetic care with some digestive issues that we commonly come across. Oh dear. So I guess it's more obvious to patients that dietitians would have a key role in neuroendocrine cancer care, and I believe that at some stage, really, every patient should be seeing a dietitian. Whether that's right at the beginning, just to kind of settle you into a better diet, or through different treatments and surgeries and preparing for surgery. There's lots of work around that at the moment. And I think as dietitians, we know that patients need to see us, and patients kind of want to see us, but there's a little bit missing in between, and this is why I do these kind of presentations and kind of raise awareness. Sometimes patients actually don't know what we do either, and I think this is really useful just to raise awareness in how actually we can help, and it's not just about giving people medication or chopping things out of their body. There's a lot of work that you have to do at home yourself, and lots of trial and error as well. So in terms of digestive problems, so I think we can categorize things as what's the cause. So is it the cancer itself? Is it the hormones or peptides that cancer is producing? Or is it causing, you know, an intestinal obstruction or something like that? And that's the cancer itself that's causing those issues. Then we have things like surgery, where you're removing parts of the digestive tract, and that can cause very different issues. Some of the drugs that we give, some of the NET treatments that we give interfere with nutrition and what you may not be able to tolerate. And then there's other therapies that occasionally we give, things like radiotherapy, which kind of takes us down a different journey in terms of the suitable foods during radiotherapy and things like chemotherapies and white cell counts and all that kind of thing. So there's always a good mix within neuroendocrine cancer patients of all these different things going on. And my job really is a bit of a detective in terms of you know, finding out what actually is causing that digestive problem, and sometimes there can be multiple causes. So the first thing I just wanted to tackle, loose stools, and within the umbrella of loose stools, actually, there's so many different causes of loose stools. So you may know a few of them, and you may not know some of them. So often hormones and peptide releases of neuroendocrine cancer is often blamed for loose stools, and not everyone has a functioning tumour. And for those people that don't have a functioning tumour and don't have all these serotonin and peptides and hormones being produced, then it's not going to be that cause. But some people, for example, with a vipoma or a carcinoid syndrome, yes, that will be part of the cause of loose stools. Well, when it's not controlled anyway on medication. Then we have problems like pancreatic exocrine insufficiency, which I know there's a lot of interest about, and I will talk in depth about that today. So where the pancreas capacity of producing enzymes, which normally break down our fat, our carbohydrate and protein, are either not working at all, not being produced, or just being produced now in too small amounts to really help you digest food. We've got Pellagra, and this is vitamin B3 deficiency caused by carcinoid syndrome. And this can cause very, very loose stools. We have things like bile acid malabsorption, so that's a very acidic diarrhea, and bile acid deficiency, so that's to do with the gallbladder and the removal of the very last part of the small intestine. We have small intestinal bacterial overgrowth, which people are very aware over here anyway, these kind of wind and diarrhea problems, especially after surgery when the bowel is trying to kind of adapt. We often see this problem. I'll talk about that as well. We've got things like overflow diarrhea. Often people say, well, I've been constipated for a few days and then suddenly I've got diarrhea, and actually that's kind of a normal process. If you have been bunged up and you've maybe had things to help bung you up and lots of loperamide and things like that, then it's a natural release to get that diarrhea, and it might not mean that there's necessarily anything wrong. It's just you may have overdosed on loperamide or something. You can get obstructions where actually the release past the obstruction will then cause diarrhea, but it's often a problem that the doctors will deal with rather than us. We've got things like hyperthyroidism, so too much thyroid hormone, and I remember once being about to see a patient who had lost lots of weight and had lots of diarrhea, and actually just 10 minutes before I went to see them, we got the results back, and they were diagnosed with hyperthyroidism. I didn't need to see them because the treatment for that is medical, it's under the doctors. So you know, monitoring the thyroid is very important. You can have IBD, so ulcerative colitis and Crohn's disease. We have a few patients who have both Crohn's disease or ulcerative colitis and a NET, and sometimes they have an intestinal NET, and these things coexisting at the same time. So it's not impossible to get different diseases. Although you've been unlucky with one, it doesn't necessarily mean you can't get other things as well. Often people are diagnosed with IBS, and I was looking at survey results from the UK actually last night. A high proportion of people are diagnosed with IBS, and there's a huge number of GP, general practitioner appointments leading up to a diagnosis of a neuroendocrine cancer. And you know, at some point someone's thought, okay, well maybe I should do a different test. You know, it's not normal to have 10 times diarrhea really with IBS and other symptoms. So I won't really be talking about IBS today, but it is something that can coexist with a neuroendocrine cancer. Someone highlighted in questions about celiac disease, and celiac disease can cause loose stools. That's one of the kind of flag symptoms to be tested for celiac disease. I will be talking a little bit about that. And then there's things like food poisoning and different parasitic infections, and these can all happen, maybe not so much in terms of parasites and worms and things like that, but food poisoning can always happen. And so if it's a sudden onset of loose stools, then and you haven't changed any treatment or drugs or anything like that, then it is possible that food poisoning could be the culprit of loose stools. So first of all, I just want to talk about pancreatic exocrine insufficiency. So 3 main causes for that. There are other causes I might just mention as well, but the main causes in neuroendocrine cancer are if you've got a pancreatic NET. Okay, so if you've got a tumour in the pancreas, a large proportion of people have pancreatic exocrine insufficiency. So this is the reduced capacity of the pancreas to make its own enzymes to break down food. If you've got pancreatic NET and you've had pancreatic surgery, then if you've chopped a bit of the pancreas out, then you may have less enzymes or no enzymes, especially if you've had a total pancreatectomy, so the whole thing removed, you've got no enzymes and you have to supplement them. And then the other thing that I personally have tried to raise awareness over the past 8.5 years since I've been working in this area is the use of somatostatin analogues. So it's a very common drug, the monthly injections that people have, and it just decreases the ability of the pancreas to make so many enzymes. So if some people will have all of those 3 risk factors, and I know one of the questions that someone wanted me to address is, you know, how, if you've got more than one risk factor, does it make you need more additional enzymes? And it probably does to some degree. If you've had a total pancreatectomy, you really know you've got none of your own enzymes working. But I think all of these risk factors have to be discussed with a dietitian. There is now evidence also that if you have diabetes and there's some kind of inflammation, something wrong with your pancreas, and of course there's things like pancreatitis, you know, whether that's chronic or acute. These kind of inflammatory kind of disorders of the pancreas can also lead to pancreatic insufficiency. So what we do, we give enzymes called pancreatic enzyme replacement therapy, so PERT for short, and they contain enzymes called lipase, which breaks down fat, protease, which breaks down protein, and amylase, which breaks down starch. If you're concerned that you have so pancreatic insufficiency going on, and you have steatorrhea, very yellow, fatty, oily stools, stools that won't flush down the toilet, then before you start the enzymes, you can get a fecal elastase test, which is a stool test, and it tells you whether you've got this pancreatic exocrine insufficiency. However, it's not been shown to be overly reliable in the NET patient population. There's a study in Wales, and they don't seem to recommend that it's overly reliable, and also you have to be off the enzyme really for it to work. So there are different PERT types, so different brands. The only medically tested enzymes are from pigs, so they're extracted from pigs and put in gastro-resistant capsules. So what that means is that when you take the capsule, it doesn't do anything until it gets past the stomach and the stomach acid. And then at the point where it enters the small intestine is where your own enzymes would normally start mixing with food and start to break it down. I know someone has asked in the questions before about Digest Gold, I think is a brand that's very common in the US, and that's a vegan supplement. So it's from vegetable-based enzymes, and there's lots of alternatives, and especially nutritional therapists and maybe more alternative therapists recommend, you know, these kind of enzymes. However, they're not medically tested. We don't know that they work at all. They're often in low doses, and if they're not gastro-resistant, there's a chance that they could be completely ruined by your stomach acid by the time it gets to the small intestine. I'm sure there'll be lots of questions about this after, so I'm happy to talk more about that. So in terms of dosing, it seems to always be too low when I see people. There's been a few times that people have shocked me and got it right, but it's very important that dosing is under the care of a dietitian. The most popular brand, I guess, worldwide is Creon, and they have 3 different doses. I know our dose is slightly different to the US one. I think yours is 24,000, but I think you've got a lower one, maybe 12,000 as well. Ours, we have a 10,000, but that's for use in children only because it's so small. We start our dosing for adults at 25,000, and that the dose really is just trying to get you used to having and taking them. And it's 1 capsule for a snack to start with, and then 2 for a main meal, and then you increase it up by 1 or 2 capsules, sometimes more, especially if you've had a total pancreatectomy. So the general rule is the more fat you have, the more of these enzymes that you have. And actually a lot of people say, oh, there's no maximum dose, or there is, it's very high though. You're very unlikely to get near it. Especially if you're heavier, because the maximum dose is based on your weight. If you're very lean and very light and you're having lots of enzymes, then you possibly could get near it. And I have had patients where we have to actually cut back because they're having 10, 15 capsules a day per snack or meal. So it's 10,000 units of lipase, which is the number on the bottle, per kilogram of body weight per day. So if you're 70 kilos, it would be 700,000 units of lipase per day. But most of you won't ever get to that massive dose. So the thing about these enzymes is that it has to be taken at the right time, or it can be completely wasted. It has to meet the food in the small intestine at the right time. So when we give these enzymes, we know that a lot of them are going to be wasted. Not all of them will make it to the food and be dissolving in your food in the small intestine. We know that some of them won't ever get to that point and they won't be active. Your pancreas, when it was working right, would have done this very well. So we have to really maximize the timing and know when is the right time to take them. So with the first mouthful of food, take half the dose, then halfway through the meal or the snack, then you take the other half. If you take them after, your food may go down and it might not meet the food and the enzymes might not meet the food at the right time. If you take them too early, the enzymes can go swimming down and then just go to your small intestine and kind of irritate the bowel. And some people, if they're taking the enzymes too early, can then get kind of rectal itching, and you can see the enzymes actually come out the other end because they haven't worked and they haven't been taken at the right time. Just on that note, actually, there is some people have this rectal irritation, but also if you open the capsules and the microspheres kind of go around your mouth, you swill them around to your mouth with a drink, they can irritate the mouth and you can have an allergic reaction as well. So obviously we need to get the timing right, and if you're then having a dessert after a meal, then you have to get the time right and have more enzymes when you have the dessert as well. So if all of this isn't working and you've increased the dose to where you and the dietitian think that it's appropriate and you don't want to go any higher, sometimes taking too much can give you a bit of wind as well. You checked you're taking it correctly, you've got your dose where it should be roughly. Some people require a PPI, so that's a proton pump inhibitor. So that reduces your stomach acid. And lots of people are on these anyway, but just taking it, one of these proton pump inhibitors under the care of a doctor, first thing in the morning, lowers the stomach acid sufficiently to then wait half an hour and take your enzymes in your breakfast. You shouldn't ever have your PPI and your creon together because it doesn't allow enough time to reduce the stomach acid. So often this is a really good way of getting your enzymes to start working, because if there's too much acid, even in the small intestine, they won't start dissolving and they won't start working. So on to the next subject. So just briefly to mention Pellagra, we're writing our first international dietary guidelines at the moment, just about finished, but we're kind of being delayed by COVID and all of us doing different jobs at the moment. But I just wanted to mention that Pellagra does cause, or diarrhea indicates Pellagra in some patients, where newly diagnosed people with a serotonin producing tumour which causes carcinoid syndrome. You can have a rash. So Pellagra basically means loose stools, poor memory, dry skin, and this, you know, syndrome we call a visual syndrome is called Pellagra. So I've actually drawn a lovely flowchart, but I'm not going to use it today because it's got to be discussed with all the other dietitians before I make it kind of live. But basically, we're yet to agree on the exact dose as an international recommendation. I personally use 100 milligrams of nicotinamide a day to prevent niacin deficiency. But I know in the US it's up to 150 milligrams per day. We really worldwide, we lack broad kind of testing of niacin deficiency. And I think we need to improve that, get more of these, they're called N1-MN urine tests to accurately test for niacin deficiency. And then when we definitely know that we've got niacin deficiency, then we can treat it. And the World Health Organization recommends 300 milligrams per day for a month in split doses throughout the day to treat this Pellagra. So often we do see it at diagnosis, and there's been 2 studies which have realised really that about 40% of people with carcinoid syndrome have Pellagra. So they, you know, it's often kind of forgotten, but actually as a dietitian it's very important that we don't forget it and we do treat people. So on to the next kind of loose stools. So bile acid malabsorption. So there are 3 different types of bile acid malabsorption. So type 1 is when there's a problem in the part of the small intestine. So the ileum. So that's the very last section of your small intestine where reabsorption takes place of bile acids. So you can have this BAM where that area of the small bowel gets inflamed, or a large section of the ileum has been removed in things like an extended right hemicolectomy. It can be due to things like Crohn's disease, or that the cancer hasn't been removed, but it's in quite a large section of that last part of the small bowel. There's type 2 BAM, which is when the gastroenterologist hasn't really found a cause, and that's called primary bile acid malabsorption. Then there's type 3 that can result from other diseases or conditions within the abdomen, such as the gallbladder removal. Often people have this removed and they're not really sure why, or it was just taken in the surgery when something else was taken out. It's always important to know what you've got and what you don't have. Things like celiac disease can cause this problem, chronic pancreatitis, radiotherapy, and small intestinal bacterial overgrowth. So SIBO can cause BAM as well. So the first line treatment is usually a bile acid sequestrant, and this is either a tablet or a powder mixed up with water, and this kind of glues these bile acids together, meaning that you don't get this acidic diarrhea. Sometimes this isn't sufficient, and actually dietitians need to get involved, and we put people on a low-fat diet alongside these bile acid sequestrants. And we have to monitor fat-soluble vitamin blood tests because these treatments can reduce our fat-soluble vitamins, so A, D, E and K. And if you're worried that you might have this problem, the diagnosis is through a CCAT scan, so you can speak to gastroenterologists about that. So the next cause of loose stools is small intestinal bacterial overgrowth. So there's two different types of this. So it's overgrowth of particular bacteria within just the small bowel, and methane exhalers, so people with an overgrowth of methane producing bacteria, these patients often have constipation, so they don't have loose stools. However, hydrogen exhalers, so on their exhaling of their test for this problem, their hydrogen producing bacteria can cause this diarrhea, and it's very severe in some cases. There's not an awful lot of research. There's probably the biggest unit, I think, is in LA, and they're doing lots of work on this, and it's kind of a bit of trial and error. We use probiotics alongside the antibiotics to treat this. We can play around with the FODMAP content, so the fermentable carbohydrates that we eat. We can try and starve the bacteria with meal gaps, so not snacking basically between meals. There's work across the world really on fecal transplants. So this, if you imagine your whole gut microbiome, it's looking at your own microbiome and then transplanting someone else's microbiome in a capsule, putting it down a tube and placing it in your bowel and changing your gut microbiome. However, it doesn't last for very long, and it temporarily causes relief of a lot of things, including things like C. difficile, but actually long term you may return to the same old problems. So there is work, and maybe one day we'll know that actually you need this transplant every 2 months or something. But at the moment it's just a bit of a grey area. With bacterial overgrowth, we also need to monitor vitamins and minerals, because some of these can get too low, and especially if you're having diarrhea and you're not absorbing food properly, we need to monitor those bloods carefully. As I said at the beginning, often syndromic diarrhea can be blamed for all the loose stools. And obviously we've got things like carcinoid syndrome. So you'd have carcinoid syndrome if your medication wasn't controlling the carcinoid syndrome. And it's certainly the case before you start your treatment, or you're swapping between treatments, and the somatostatin analogues don't work, very well anymore, and you need to go on to the next treatment. But there's also syndromes of very, very bad diarrhea, really watery stools 20 to 30 times a day from tumours called vipomas. So that's the kind of syndromic diarrhea. And so if we're talking about carcinoid syndrome, and I know there was questions about dietary triggers, I'm aware of the work that was done, I guess it was over 10 years ago in the US, and there was a short survey about what people's triggers were for carcinoid syndrome. It's not really a well-studied area. There's not been much since then at all. What we do know is that carcinoid syndrome diarrhea will continue with or without food. And if we're, a lot of people say, well, I need to starve myself to be able to leave the house. It probably will continue whether you starve yourself or not. So actually we need to just be aware of the right foods and drinks. It's, yes, medication will hopefully control all of the symptoms, but there may be, for a small proportion of people, triggers through the food, and these are particularly the high vasoactive amine foods. I'm aware that survey told people that maybe high fibre foods or alcohol and high fat foods caused carcinoid syndrome. Yes, there may be vasoactive amines, which I'll talk about in a minute, in alcohol. However, things like high fibre, high fat, very unlikely to trigger carcinoid syndrome. They may trigger loose stools or other types of diarrhea, but it's very unlikely that they can interact on a biochemical level and cause carcinoid syndrome. So I think in terms of carcinoid syndrome and vasoactive amines, so these will be coming up in the guidelines. So vasoactive amines, for a very complicated pathway, can trigger flushing, especially in some people. And these are the categories from quite a good paper that we've used in our guidelines. So it's kind of aged products and cured products, tinned meat, processed meats and fish. Those cheeses, so any old kind of aged protein products, but also things like oranges, bananas, tangerines, pineapple, grapes and strawberries, and those juices and those in smoothies can be an issue for some people. Tomatoes are on the list. Some people do have an issue. It's not that common. But things like pickled cabbage and kind of beans and some of the nuts as well, fermented soy products. So in Asian cuisine, a lot of these fermented old products can cause an issue. And things like green tea and champagne. So it's actually wine and champagne from oak barrels tend to be more of an issue than other, just I guess metal barrels that they produce wine and beer in. So with food triggers, I know it's always a popular topic on chat groups and Facebook and everything. So that is not a list to exclude. Really, if you think you have any food triggers, then you need to speak to a dietitian. And then when you're with a dietitian, you need to present them with a food and symptom diary. So what have you eaten, what time, how much, and then write down any symptoms that you've had later in the day. Food triggers will cause an issue, especially flushing, sometimes diarrhea, but especially flushing within about an hour. Often it's more immediate than that. So you need to write down if you've had the flush or diarrhea after you've had that. And by seeing a dietitian, that you know that your diet's going to be adequate and you're not cutting out things that you don't need to, because if you don't react to these foods, you don't need to cut them out. As I mentioned before, alcohol, and this was in one of the questions I received in the pre-questions that I saw, alcohol such as the oak barrel wines, and I don't know whether they use it in beer, but some of those alcohols can cause a flush in some people. But even without carcinoid syndrome, alcohol can cause flushing. Whether this flushing is dangerous, we don't know. We haven't had any research in the area. I would say it's unlikely, but we could really do with some research about what actually happens, what's biochemically, what's actually happening when you have these vasoactive amines. Just to mention also, I think if you are having lots of carcinoid syndrome for any reason, and you're having lots of loose stools for any reason, you should really be having a fluid and electrolyte replacement. So these are the drinks that you mix up. They're often flavoured with glucose and a kind of a fruity flavour, and potassium and other electrolytes and salt. You lose a lot of salt, especially if you vomit as well. You have to replace these salts and the fluid that you're losing. So on to celiac disease. So 1% of the US population have celiac disease. And some patients with neuroendocrine cancer also have celiac disease. I know gluten-free is very popular these days, and going gluten-free, you know, it can help some people. However, it's not something that we use in neuroendocrine cancer. Basically, people often find going gluten-free helps, and it may actually be to do with the natural chemicals within the wheat. It's not often gluten that's the problem. If you have celiac disease, however, gluten is the problem. And if you do have symptoms of that, and often it's leading up to a diagnosis, you might be tested for celiac disease as well, but it's a simple blood test. If that blood test comes out positive, then you can go for a small bowel biopsy, and it looks at the little hairs, they're called the villi, which absorb your food, and if they're flat, then in that biopsy you would have to go gluten-free. But certainly we don't recommend gluten-free kind of on its own as a treatment for loose stools unless you have celiac disease. I will add though that there are low FODMAP diets. So if you have loose stools and you have suspected IBS, we might use a low FODMAP diet, which is the fermentable carbohydrates, reducing those because they can cause loose stools and wind. And a dietitian may trial you on a low FODMAP diet, which does include wheat-free, gluten-free, basically. So it could be a possibility that that you do have IBS, and but you have to see a dietitian for the low FODMAP diet because it's rather complex and very difficult to follow. So on the opposite end of the scale, we've got problems like constipation. And actually, when we did a survey a few years ago, what were the kind of side effects when you started a somatostatin analog? And actually the highest percentage of people said that constipation or difficulty going to the toilet, or going to the toilet and then feeling that you haven't really completed what you wanted to do and you go back an hour later. So this is a big problem for people, and it might not be all the time, but sometimes you can get this constipation. It's a common side effect of somatostatin analogues and having too many painkillers, some of the painkillers. So we would look at the amount of fibre that you're having. Sometimes people have loads of fibre and not enough fluid. And if you're having high fibre diets, then you need more fluid to go with that. So sometimes it's about cutting down on the fibre, or some people don't have any fibre at all and we'd need to increase the fibre, which stimulates the bowel and make sure that you're having enough fluid, making sure that you're keeping as active as possible to help the bowel move the food through your system. If you're in a hot country, then you need to replace fluid more often, obviously. As I said earlier, the methane exhaling people with small intestinal bacterial overgrowth can get this constipation and wind, really painful trapped wind. We can introduce things like flax seeds or linseeds or linseed powder, and this is really good at stimulating the bowel to kind of help someone pass a stool. There are fibre supplements, you know, either roughage or psyllium husk, or the soluble fibre supplements, which can help. As I said, making sure that you have enough fluid and keep moving as well. There was a question about gas and wind. So obviously you can have gas going up, or you can have gas going down, or it could be stuck somewhere in the middle, and that is painful. It's not a nice thing to have at all. And if we're thinking about what can cause gas, you either swallow it. If really fast eaters get a problem with gas, fast drinkers, because they're swallowing a lot of air and then it's getting stuck in the stomach and they burp it back. But apart from that, things like chewing gum are an issue. And if you've got a lot of acid being produced, or you've got, you know, a disarray in your bacteria in your gut, that the bacteria are eating certain foods and then releasing more gas. So really, if you've got an ongoing gas or wind problem, then it's best to see the dietitian, because it may be that you need to play around with these fermentable carbohydrates, or maybe you've got wheat intolerance. It could be that you're having too much fructose, so too much fruit. You may be lactose intolerant. It may be the pancreatic enzymes that you're on. You know, they're causing the gas, and you might need to change the brand. Eating too quickly, all the kind of gassy veg like the cauliflower, the broccoli, garlic and onions are often a big problem for people. But you could try things like peppermint tea, charcoal tablets. I don't know whether you use them over there. Some people, it's not something that I recommend, but people have used charcoal tablets and find them to be quite good. So yeah, it's kind of like a lot of things. It's a lot of kind of trial and error. So I think that's the main topics that were on the presentation, and I'm aware there'll be lots of questions probably to follow. Those are my contact details on social media or email if you want to get in touch. So I don't know, is someone gonna?
Barry, are you there?
I am.
Okay, so can you put me back on, or I can guess I can do my own to start.
Hang on.
Thank you, Tara. This was very, very informative. And obviously, we don't like talking about stools and constipation and things like that, but you have very directly and maybe delicately, I don't know, but directly address the issues for us. I think your talk has given us much more in-depth understanding about some of our issues. There are a couple of other questions that have come up since you started talking. I don't know if you're familiar with the Berry Health Blackberry powder. It's a product that is produced in Oregon in the US. And one of our NET specialists in this country, who is now retired, Dr. Eugene Waltering, was a proponent of drinking a drink made with blackberry powder. Some of us have used it I did for a number of years early on. I haven't used it recently, but do you know of any particular benefits that are derived from the blackberry powder?
I've not heard of it actually. It's difficult to know without seeing the ingredients list, but I haven't heard of it. I know, so blackberries, presuming that it's just a kind of freeze-dried blackberries can cause an issue, and they are high in FODMAPs, I think. I'd need to check the list, and can cause diarrhea. But berries in general, if you don't have gastrointestinal issues, are good. And they have lots of phytochemicals in them, which are, you know, plant-based antioxidants and things like that. So I've got nothing against them, but whether it helps with digestive issues, I don't know.
Right. My experience was it made my stools darker, so they looked more normal. But I'm not sure that it did anything else. And it was at that point when I was doing it difficult to keep mixing the drink. I think it's now in a formula that's easier to use.
Okay.
And you might like to look that up. It's the Blackberry farm. I think it's just called Berry Health, is berryhealth.com is their website.
Okay, lovely.
Another question is, will a diet with low amine foods, I know that you mentioned low amine foods in your talk, but does that shrink tumors and or just control diarrhea?
So we don't have any research in the area. It's all theory at the moment, and I wouldn't have thought that it would shrink tumours. And as I said, you only reduce these vasoactive amines if they cause a problem for you. And the only way of knowing that is by doing a food and symptom diary.
Okay. Someone also asked about chocolates and cheeses. How much is too much?
So if you do react, so if you do have a flush or a flush and diarrhea within an hour of having an aged cheese, or especially dark chocolate or hot chocolate, then you probably just need to eliminate it. There's no real, you know, if it doesn't harm, we don't really know whether it harms or not to have this flushing with food, but you know, it's up to you whether you want to put up with those symptoms or not, and you're probably best just to avoid those things if they cause an issue.
Mm-hmm. So the dark chocolate is worse than the milk chocolate because of the cocoa content?
Yeah.
So yeah, even though dark chocolate is promoted as better for us, it's not better for us.
Well, it depends. I mean, there's not that many people. I've met a lot of patients, and there's not that many people who do react to these vasoactive amines.
Mm-hmm. And on the cheeses, is it the hard cheeses or the soft cheeses that are more likely to cause problems?
So mainly the hard cheeses. I always say try and go for the kind of fresh or cream cheeses, which tend to be, you know, younger and less, you know, it's the aging process. It's making something old that releases these vasoactive amines from food and aging the protein.
Thank you. That's helpful. I personally like dark chocolate, but maybe I'll move to the milk. Then there was another question about treatments for diarrhea. A lot of us are either on Creon or Zermello. If those don't work, what's your advice?
That's a really difficult question, because we need to look at everything that's going on with someone, and it's not possible really to answer that. We need to look at what's causing the loose stools. So it's not as simple as that kind of question. Both of those treatments are treating different types of loose stools. So if you do have access to a dietitian who specialises in this, then that's the best option. If not, an oncology or gastroenterology dietitian, or a gastroenterologist or NET specialist or NET specialist nurse, are best to kind of delve into this area a bit more.
Okay, that was my next question. What medical professional do we go to next? And we've had a hard time identifying dietitians and or nutritionists in our area who are NET specialists. Do you happen to know any US-based NETs dietitians?
There are a few, however, practicing privately, so outside of their centres. So Leanne Burns has retired, and she, I think, is planning still to do private practice.
That's the one I do know.
But outside of people's, if you work full time, it's very difficult to then see people privately as well, because you'd just be working 24 hours a day. So private wise, I'm not sure. I know you can always email these dietitians. I know when I've listened to their presentations, they're always happy to receive inquiries and the short questions. But really, when I see people, it's you have to know the whole picture, and it's a very lengthy process. It's not as easy as just saying, what's going to help my diarrhea, because it's too complex, I think, just to answer something simply like that.
Right. I've received one more question. For patients who still have their gallbladder and they don't have diarrhea, or it's controlled by sandostatin or lanreotide, what would you think causes a breakthrough of loose stools? Is it just food, or is it too much serotonin being produced by tumors that aren't controlled by the somatostatin analog?
Well, there's obviously lots of causes of loose stools. If it's something sudden, then you need to track down what actually changed at that point where you started to get the loose stools. So it's quite a difficult question without knowing everything.
Right.
If someone, for example, quite commonly we get people that were diagnosed 5-10 years ago and they've occasionally had carcinoid syndrome. This is nothing to do with the gallbladder, but they've had carcinoid syndrome, and they may have lived with carcinoid syndrome, not really know that they have a tumor for 15 years, and they've never had nicotinamide replacement. I think you can see pellagra and loose stools because of that, for example. So, but obviously, if you've had surgery and you've had part of the bowel removed, then you can get things like bile acid malabsorption or small intestinal bacterial overgrowth. So, and also stress. I mean, I haven't talked about stress, but stress is a massive factor which causes an upset stomach. So it's looking at those kind of things as well.
Well, thank you very much. We appreciate your time. I know we've gone over the amount of time that we discussed that you would be with us, but this has been very informative, and we appreciate your willingness to take some of your Saturday time to join us. This has
Thank you very much.
been great. Thank you.
All right, I'll leave you to have your normal group meeting now.
Thank you so much.
All right, thank you.
People will be in touch with you, I'm sure.
All right, take care, everyone.
Goodbye.
Bye.
Nice meeting you.
Bye.
Bye-bye. Okay.